The nephron is the major functional unit of the kidney. Each kidney contains approximately 1 million nephrons. Every nephron is composed of two main parts, the glomerulus and the renal tubules, which together carry out the essential processes of filtration and reabsorption. The glomerulus is a coil of capillary vessels that serves as a non-selective filter of plasma substances smaller than 70,000 molecular weight. It filters substances such as water, glucose, electrolytes, amino acids, urea, uric acid, creatinine, and ammonia, which together make up the glomerular filtrate. The glomerulus filters about 120 milliliters per minute, which is approximately 1/5 of the renal plasma. This is known as the glomerular filtration rate. Urine is primarily composed of water, accounting for about 95% of the excreted volume. The major organic component is urea, a metabolic waste product formed in the liver during protein breakdown. Urea makes up about half of the dissolved organic solids in urine. Other organic solids include uric acid and creatinine. In addition, inorganic solids such as chloride, the primary constituent, along with sodium and potassium are present. The proximal tubule plays a crucial role in reabsorbing water. Sodium chloride, bicarbonate, potassium, calcium, amino acids, phosphates, protein, and glucose. Glucose is considered a threshold substance and is normally reabsorbed at concentrations of 160 to 180 milligrams per deciliter or less. The proximal tubule also secretes sulfates, glucuronides, hydrogen ions, and drugs. The descending loop of Henle reabsorbs water but does not reabsorb solutes. In contrast, the ascending loop of Henle reabsorbs solutes such as sodium, chloride, calcium, and magnesium, but does not reabsorb water. Finally, the distal and collecting tubules reabsorb sodium and secrete potassium, ammonia, and hydrogen ions. Potassium ions in this region are exchanged for sodium ions to help maintain the body's electrolyte balance. In healthy individuals, the average urine volume ranges between 1,200 and 1,500 milliliters per day. Under normal circumstances, there are no specific diseases or conditions associated with this volume. Polyuria refers to the production of more than 2,500 milliliters of urine per day. This condition is commonly seen in diabetes insipidus and diabetes mellitus. It can also be caused by the use of diuretics, or by consuming substances such as caffeine, alcohol, and excessive amounts of fluids. Oliguria is defined as the production of less than 400 milliliters of urine per day. It is often associated with dehydration, vomiting, diarrhea, burns, or excessive perspiration. Anuria means the complete cessation of urine output. This severe condition usually results from kidney damage or a significant decrease in blood flow to the kidneys. Nocturia refers to increased urine production at night. It is frequently observed in individuals with renal disease, during pregnancy, in men with an enlarged prostate, or in those who consume excessive fluids before bedtime. Aldosterone is produced in the adrenal cortex. Its primary action is to increase the rate of sodium reabsorption in the kidney. By doing so, it helps regulate fluid balance and blood pressure. Arginine vasopressin, also known as antidiuretic hormone or ADH, is secreted by the posterior pituitary gland. Its action is to promote the reabsorption of water from the distal tubules of the nephron. This hormone is essential for maintaining water balance in the body. A deficiency of arginine vasopressin leads to diabetes insipidus, a condition marked by excessive urination and extreme thirst. Erythropoietin is produced by the kidney. Its role is to stimulate the production of red blood cells, or erythrocytes, in the bone marrow. This hormone is vital for maintaining adequate oxygen-carrying capacity in the blood. Bilirubin metabolism begins when hemoglobin from red blood cells is broken down in the reticuloendothelial system. This process produces unconjugated bilirubin, which is not water-soluble. The unconjugated bilirubin is carried to the liver, where it is converted into conjugated bilirubin. Once conjugated, bilirubin becomes water-soluble, making it suitable for excretion from the body. The conjugated bilirubin moves into the intestine. Here, it is transformed into urobilinogen. About half of this urobilinogen is excreted in the feces as urobilin, which is what gives stool its typical brown color. The other half of the urobilinogen is reabsorbed and recirculated back through the liver. A small fraction escapes this cycle and is filtered by the kidneys. This portion is excreted in the urine as urine urobilinogen.